I'm delighted to welcome you all together for the next McCance Center faculty seminar. We have two terrific speakers today, and in the interest of really getting as much to people in as efficient a package as possible, we've got half-hour presentations arranged. So welcome everybody. I'm delighted to introduce Dr. Pamela Rist, who is assistant professor at HMS and at the Chan School of Public Health and associate epidemiologist in the Division of Preventive Medicine at the Brigham. We're thrilled to have Dr. Rist because her academic interests are primarily focused on the epidemiology of cardiovascular disease, particularly stroke and neurologic diseases, with the goal of identifying ways to reduce morbidity, and particularly with a focus on prevention. So Dr. Rist, please take it away.
Great, thank you for having me. I'm just going to share a few slides. Can everyone see that?
Looks great.
Great, let me just full screen that. So thanks for having me here today. I'm excited to talk to all of you about some of my work leveraging longitudinal cohort studies to try to understand the morbidity burden of migraine and stroke. So as you just heard, my training is as an epidemiologist, and in particular, I'm very interested in that intersection of cardiovascular and neurologic diseases. So most of my work tends to focus on diseases like stroke, migraine, or cognitive decline, where we see interactions between those two systems. The overall goal of my work has been to try to reduce the morbidity burden associated with these diseases. So in addition to looking at what are some of the risk factors for stroke, I'm also interested in looking at how do we make sure that people have better outcomes after their stroke? What things prior to the stroke event might determine whether or not you develop post-stroke dementia, for example. I'm also very interested in the health effects of migraine. So if an individual already has migraine, does that mean that they're also at increased risk for other diseases, such as cognitive impairment or stroke? And then finally, I've done some work on that intersection between cognitive impairment and functional limitations, and how we might be able to ameliorate the link between cognitive decline leading to functional decline. So as was mentioned in my intro, I sit over in the Division of Preventive Medicine. So just to give you a little bit of a sense of the types of studies that we have over there, we're known for doing large-scale randomized prevention trials, which we then turn into observational follow-up studies. So we often are trying to answer a primary research question: does aspirin prevent the risk of cardiovascular events in middle-aged and older women? But then after we're done answering the research question from the trial, we continue following the participants in an observational manner. And this has resulted in a really neat ability to look at very long-term effects of lots of different exposures. Today, I'm mostly going to be talking about two of the cohorts that we have. We have many others as well. But first, I wanted to mention the Women's Health Study. So the Women's Health Study was a completed randomized trial of the effects of low-dose aspirin and vitamin E in the primary prevention of cardiovascular disease and cancer among nearly 40,000 US female health professionals who are aged 45 years or older at baseline. So the trial itself ended in the early aughts, but we were continuing to follow the women on an observational basis. And we actually have funding through 2025 right now. So by the end, we'll have nearly an average of 30 years of follow-up on many of these women. So we really have the ability to look not just at short-term exposure periods, but much longer-term exposure periods in that cohort. And because the cohort was designed to look at risk factors for cardiovascular disease, it's really been a useful database for me to use as well for my research. The other study that I'll mention at the end is a more recent trial. So this is the VITAL trial, the vitamin D and omega-3 trial, which looked at the effects of vitamin D3 and omega-3 fatty acids in the primary prevention of CVD and cancer among about 26,000 individuals. Active treatment ended in December 2017, and we're still doing observational follow-up. So in VITAL in particular, I've had the ability to add in new things during the course of the trial and during observational follow-up to answer some of the research questions that I'm particularly interested in. So I know I'm probably biased, but I do think that our cohorts are a good resource for studying brain health. Part of this is because we have a wide variety of information. Many of the trials were designed with cardiovascular disease events, including stroke, as one of the primary outcomes. So we have a lot of clinical outcome information, and by this point, a lot of events as well, given the size of the cohort and the length of our follow-up. But then we also have other events too, like cancer, Parkinson's disease, or MS, if you're interested in those. Many of our cohorts do have a subset with cognitive testing. Another big resource that we have is biomarker information, as well as stored blood samples. So we're able to go back and actually measure novel biomarkers in these samples as new novel risk factors for brain health arise. We also have information on many other health conditions besides the primary endpoints of the trials. So for me, we have very rich information on migraine. We have hypertension, hypercholesterolemia, diabetes, lots of different things, really allowing us to get a full spectrum of what is the health of this individual. And then finally, we also have lifestyle information. So we ask very detailed physical activity questionnaires. Some of our cohorts even have accelerometry data. We ask about alcohol consumption and diet. We even ask about pet ownership. I just saw that question recently when I was going through a questionnaire. So a wide variety of different factors. What I want to do today, though, is sort of highlight two studies that I've done to try to illustrate the types of opportunities that are available in our cohorts and how I've been able to leverage the data that we have to look at unique brain health outcomes. So first, I'm going to start by talking about migraine and functional outcomes from ischemic cerebral events. And then I'll end by talking about vitamin D and omega-3 fatty acids and longer-term stroke outcomes. So as many of you, I'm sure, know, migraine has been linked to an increased risk of stroke. In particular, there's been an increased risk of ischemic stroke among those who experience migraine with aura, about a doubling in the risk. And this has been shown in cohorts like the Women's Health Study, as well as many other cohorts throughout the world. However, there was a lack of information on whether or not individuals who experience migraine, particularly migraine with aura, tend to have more severe strokes. So does this increased risk of stroke also lead to worse functional outcomes after stroke? Interestingly, there was one study that suggested that migraine with aura may be linked to lacunar stroke, but it wasn't actually able to look at outcomes from the stroke. So what we did was we decided to analyze the association between migraine and functional outcome from incident ischemic cerebral events using data from the Women's Health Study. So one of the strengths using the Women's Health Study to look at this type of question is the size of the study. So at baseline, the women were asked, have you ever had migraine headaches? And in the past year, have you had migraine headaches? They were also asked about the characteristics of their attacks, including the presence of aura, because that really seems to be the feature that confers the most risk. Based on the women's responses, we're able to group them into 4 different exposure categories. First is no history of migraine. Next is past history of migraine. So these are women who have experienced migraine in the past, but not within the year prior to baseline. And we often see that these individuals have a different risk of cardiovascular events than people who were actively still experiencing migraine at baseline. So our next 2 categories were active migraine with aura. These are women who have had migraine in the year prior to baseline and reported experiencing aura. And then we have active migraine without aura. So then what we did is we follow the women through time for outcome events. So in the Women's Health Study, all of them are female health professionals. So the first stroke or transient ischemic attack is self-reported during follow-up. And then after a woman self-reports an event, we ask for permission to review medical records. And we have an endpoints committee, which uses these medical records to either confirm or disconfirm the self-reports. And for the confirmed strokes, they also assign a modified Rankin scale score to all of the confirmed events. So this modified Rankin scale score is what the Women's Health Study has as their outcome from stroke. One of the downsides to the Women's Health Study is we don't have longer term outcomes, but we at least know at hospital discharge, how is the individual doing? We decided a priori to categorize the score into 3 levels, 0 to 1, 2 to 3, and 4 to 6. This means that our possible outcomes are going to be no stroke or TIA, so no event at all, TIA only, sort of capturing that as a mild ischemic event, and then ischemic stroke with our 3 categories of the MRS, roughly representing mild, moderate, and severe outcomes. So just in the interest of time, I'm going to skip to the punchline from this study. So this graph here is showing the relative risks for individuals who have migraine with aura. Those are the blue bars. And the red bars are individuals who have migraine without aura compared to individuals with no history of migraine. So our reference group is always individuals who have no history of migraine. And then for our outcomes, we're looking at what's their risk of a TIA compared to no event, or what's their risk of a stroke with a mild outcome compared to no event. So women who report migraine with aura seem to be at increased risk of a TIA or an ischemic stroke with a mild outcome, so this MRS 0 to 2, but they're actually not at more risk of these unfavorable outcomes. So we do still see the link between migraine with aura and an increased risk of stroke, but in particular, it seems to be these strokes with a mild outcome. And there's a hypothesis that maybe the association between migraine and ischemic stroke may be due more to microvascular phenomenon. And we're currently trying to write additional grants to delve into this more and to look more at what are the types of strokes that individuals with migraine get? Why might they be different than what we see in individuals without migraine? So I wanted to start with this. This is an older paper, but it gives you a sense of the types of questions that we can answer with data that we already have existing in our cohorts, and that answers the question in a novel way. The sheer size of the women's health study allowed us to split up the women into 4 different migraine categories and 5 different outcome categories. So that was one of the big advantages to this. Now, in addition to looking at migraine and cardiovascular or cerebrovascular diseases, we've also looked at many other different health effects using data, again, from the women's health study. So we've looked at things like cognition and depression. We've looked at other sort of factors that lead to an increased risk of CVD, such as hypertension, diabetes, BMI. We've also looked at other neurologic conditions like restless leg syndrome or Parkinson's disease. We did a few papers on cancer, particularly ovarian and breast cancer. We've also looked at lifestyle habits like dietary patterns and migraine. Another thing I just wanted to highlight too, is one of the big strengths of the women's health study is we have biomarkers, so a large panel of cardiovascular disease biomarkers measured on about 27,000 women at baseline. So we've been able to use this biomarker panel to look at the association between migraine and CVD biomarkers. In addition, also from these blood collections, we've obtained genome sequencing and exome sequencing, and we now contribute to many different genetic consortium in migraine as well as in other diseases. So the other reason why I wanted to talk about migraine and stroke outcomes first is because it allows me to pivot into some of my more recent research on stroke outcomes. So the Division of Preventive Medicine has done numerous studies examining risk factors for stroke within our cohorts. So does aspirin prevent the risk of ischemic stroke? Does it increase the risk of hemorrhagic stroke? What really is the association between cholesterol levels and stroke? What I've tried to do recently, though, with some support from a K Award, is try to expand this work to look at how pre-stroke risk factors influence post-stroke outcomes, as well as markers of subclinical cerebrovascular disease at the time of the stroke. So basically, there's many stroke cohorts where they enroll individuals at the time of their stroke, and they get a variety of rich information about outcomes and imaging measures. I was curious, well, could we do this within the context of our large cohort studies? Could we start looking at longer term outcomes? So can I collect outcomes a year after the stroke? Can I obtain copies of those MRIs that are performed and analyze them for imaging markers? And the reason why I wanted to do this is that most studies on risk factors for post-stroke outcomes or subclinical cerebrovascular disease are usually done among cohorts of stroke patients. So we enroll individuals after their index event. And this design has contributed a lot to our knowledge of the risk factors for post-stroke outcomes. But there's also been some limitations to those design decisions. So first, the stroke event itself and its therapeutic consequences might modify the status of risk factors, particularly some of those biomarkers, making it difficult to determine the participant's true risk factor status prior to the stroke. In addition, many of these studies have not been able to explore how risk factor status years prior to the stroke may have influenced outcomes. So what was the participant doing 5 or 10 years before their event? And how might that influence their brain health today? And then finally, the severity of the stroke often limits the ascertainment of some risk factors, particularly those self-reported lifestyle ones. And I really thought that our longitudinal cohorts would offer the unique opportunity to expand upon the prior work and to explore the association between pre-stroke risk factors and post-stroke outcomes. So I could leverage all of that data that we've been collecting for decades to obtain the pre-stroke risk factor information and then add on more detailed collection of post-stroke outcomes. So the main study that I did this in for the purpose of my K was the vitamin D and omega-3 trial. And what I did was I sent a detailed stroke outcomes questionnaire to individuals who experienced a stroke in this cohort. And we used information from the Framingham Disability Study. That was the questionnaire that we sent out. And this questionnaire assesses functional limitations as well as physical function. They also have a measure of something that they term social disability, which is a combination of IADLs, as well as questions about whether your social interactions with other people and how fulfilling they are. And what I decided to do was look at the association between randomized treatment assignment to vitamin D or omega-3 fatty acids, so that was the overall goal of the trial, and post-stroke outcomes. So this idea, just taking vitamin D or omega-3 fatty acids in the years prior to your stroke, influence how you do about a year after your stroke. So again, just in the interest of time to sort of highlight the punchline from this work. So in the VITAL trial, we had 290 individuals experience their first stroke during the trial. And 42 of these events were fatal events. And then a few more individuals died prior to me being able to send out the questionnaire. So in the end, we had 197 stroke survivors who completed that questionnaire about 1.4 years after their stroke diagnosis. The graph on the right summarizes our main findings. So the first two colored boxes, the blue versus the red, is showing do those who take active vitamin D have a decreased risk of functional limitations or physical disability compared to those who take placebo. And we saw no association between vitamin D and functional limitations or physical disability. You can see that all of these red boxes are basically at 1, which is the null. However, when we started looking at omega-3 fatty acids, we observed some signal that those assigned to omega-3 fatty acids had a non-significantly lower risk of functional limitations and physical disability after their stroke. So our numbers are small here. I am only talking about 200 events, but still some promising signals that there may be an association between omega-3 fatty acid use and a lower risk of limitations post-stroke. In addition to this work, we've also been trying to look more at risk factors for subclinical cerebrovascular disease among individuals with stroke. So mimicking what many of the stroke cohorts do and seeing, can we replicate their findings? Can we look at hypertension status, not just at the time of their stroke, but 5 or 10 years prior, and how might that influence their cerebrovascular disease burden? So we've been obtaining copies of MRIs performed at the time of the stroke in the Women's Health Study as well as VITAL, and using these to look at how risk factors years prior to the stroke might influence subclinical cerebrovascular disease burden. So just to wrap up, I wanted to mention some of our current and future directions. So right now, we actually just completed another large-scale trial called the COCO Supplement and Multivitamin Outcome Study. And in this trial, I've actually also been doing the stroke outcomes and MRI data collection. So the goal is that across multiple cohorts in the division to get our own internal stroke outcomes cohort. We also recently received funding to look at some novel biomarkers for cognitive function within the context of this study. Again, this study, like many of the others, collected blood samples from participants throughout the course of the study. And now we're able to go back and measure new biomarkers that maybe we didn't know about when we first designed the study. Going back to sort of my interest in migraine, we recently received funding from the NINDS to look at biomarker signatures for migraine classification. So there's been a lot of interest in whether or not we could develop a biomarker signature for migraine that could be used in diagnostics, could be used in clinical trials, and it could be used to find new targets for migraine treatments. And we're going to be using, again, the Women's Health Study and measuring a large proteomics and metabolomics panel and trying to look at any of those factors. Or will they help us distinguish individuals with migraine and different features of migraine from those without migraine? Looking ahead, so the Women's Health Study, when they were first enrolled, they were 45 years or age and older, but as you can imagine, they're getting older now. They're in their late 70s. So we've recently obtained a supplement to the main Women's Health Study that's allowing us to look at CMS data to obtain dementia diagnoses, to see, can we look at risk factors for dementia in the Women's Health Study, to see whether or not it's feasible to do within the context of our cohort. And then finally, I didn't have a chance to talk about this today, but most of my work on prevention of things like migraine and stroke has actually shifted into some work that I'm doing at the Osher Center for Integrative Medicine. So we're looking at whether or not tools like biobehavioral therapy can decrease migraine disability. And we're also looking at how opportunities like Tai Chi might actually help with cognitive impairment as well. So that's sort of where some of my other work is right now too. So hopefully I'm about at 20 minutes and I've left enough time for questions.
That was terrific. Thank you. Yes, we do have some time for questions, and we'll lead off with Dr. Golub's question about more about the details of how migraine is ascertained, and you can pick in any of the particular studies that you think is relevant.
Yeah, so I'll talk about the Women's Health Study, because that's probably the cohort where we did the best job. So it is self-reported, so it's a physician diagnosis. But then for the women that did report migraine, we actually sent them a much more detailed migraine questionnaire that allowed us to assess symptoms and to see, do their symptoms meet the diagnostic criteria. One of the limitations, we do get criticized for the fact that we're doing self-reported migraine, but I like to remind people that it's over 6,000 women that have some sort of history of migraine at baseline. So doing the one-on-one neurologist interviews, the gold standard, often isn't feasible. So instead, we'll do these validation studies, or we'll ask people to self-report, have you ever been diagnosed? And then we'll ask them more details about their symptoms. And we've done the same thing in the VITAL study as well, to try to verify those self-reported migraine symptoms.
Well, one of the things that I noticed that was really interesting is that amongst your migraineurs, even though the incidence of the lower severity strokes went up, the more severe ones look like they went down. You didn't comment. I don't know, maybe it wasn't significant.
Yeah.
But it made me wonder whether something about having migraines makes you more, or having severe headaches of some sort makes you more sort of aware of and thinking about your brain and how it feels, or what's going on inside your skull and how it feels, and whether that there might be a observation bias, that they might be more sensitive to noticing, subtle differences in how they're feeling, thinking, brain is working compared to your typical person who doesn't have headaches.
Yeah, I think that is one of our worries, particularly for the TIA results, that it might sort of be that you're capturing every single case among the migraineurs, but you're missing some among the non-migraineurs. I think for the more severe categories, those were not statistically significant. I just didn't have the bars on them. But there's been other studies too that have used other ways of assessing migraine that still show the link between migraine and stroke. It just so happens that our cohort, we were able to see, is it the more mild events or the more severe events? But maybe in general, that is one of the things that we know migraineurs tend to have health-seeking behaviors. So maybe we are capturing all of the events among individuals who have migraine, but not among the others. The one nice part with this cohort is that it is all female health professionals. One of the reasons that they did the study initially among female health professionals is they were hoping that they would get more accurate self-reported outcome information. Whether or not, I mean, we could debate whether or not that was true or not, but at least in the women's health study, and then there's also other cohorts like the nurses health study and the health professionals follow-up study, that it's one of those, we need the size, so we have to make some efficiencies to try to get this much info on 40,000 people. So that's but yeah, there's limitations.
Pamela, one question that comes up is how representative of the population are these cohorts? It's often a challenge in these research studies that you end up getting people who are either used to participating in research, particularly motivated, but I'm curious from what is the makeup?
Yeah, so this one, I don't have a slide with the makeup. The cohort is predominantly white, unfortunately. So that's probably one of the big limitations to its representativeness. It is all health professionals too. So we're probably dealing with a cohort that is more educated compared to their other peers, given these women's birth years. At the time, though, that the women's health study was started, it was somewhat unusual to have women in clinical trials. So that was one of the big developments in this, that telling the women, like, no, you can do this. We can do the physician's health study in women. So yes, it's the same criticism that we often have with our studies, people who participate in trials. There is often something different about them. I think though that still that relative associations that we find, how many times higher is your risk, that's still getting at biology. Whether or not we're seeing the absolute number of events that other cohorts would see, ours are probably lower than some other cohorts are. But a lot of these have been replicated in some of the other studies that are a little bit more representative. But yeah, it's a common criticism.
Another question that's come up is, could you speak a little bit to the biomarkers that you're looking at in Cosmos, and whether there's an opportunity to expand, if you were to get additional funding, the number of biomarkers?
Definitely. So that's the cool part with all of the studies. Even Vital has a lot of cognitive testing as well. The women's health study does too, less than Vital or Cosmos. So what we're planning on measuring is we're going to measure neurofilament light, a new marker of tau, and some of the amyloid beta measures as well. So yes, with more funding, we can measure more. So we have a collaboration with Dennis Selklo's lab, who's over at the Brigham, and we're working with him to measure the biomarkers. We're always happy to work with other people. And that's the cool part with the cohorts, is we do try to bank biospecimens so that we can measure novel things as they come up.
Any more questions for Dr. Rist before we turn over? Okay, well, thank you so much. Appreciate your packing so much into a brief presentation. We will be inviting you back, so hopefully you will find that this community is fertile for collaborations.